Hello, everyone, and welcome back to the Generalist Low Risk Obstetrics podcast. We are your hosts, Kyla Freeman, Family Medicine +1 in Obstetrics, and Patricia Massel, fully fledged family doctor, locuming somewhere near you, I'm sure. Today, we have put together a sweet episode for you. We are going to focus on diabetes and pregnancy. Since we also care about newborn management, we'll briefly cover blood glucose monitoring and the management of hypoglycemia in the immediate postpartum period as well.
This podcast was written by Kyla Freeman and reviewed by Dr. Charley Boyd. Key resources include the Diabetes Canada website, the 2018 GESO-GC guidelines on diabetes and pregnancy, up to date, and the 2019 CPS position statement on screening and management of newborns at risk for low blood glucose.
So, as you all know, diabetes is a huge topic. It is an area that requires a lot of expertise and a collaboration across providers. Today, we are going to restrict ourselves to gestational diabetes and hypoglycemia in the newborn. We will do our best to bring you an episode on pre-existing diabetes and pregnancy at a later date.
As for all our episodes, this is meant to get you thinking about the issues in pregnancy and hopefully highlight some useful resources to turn to. We do not represent any of the organizations from which we draw our information, and any opinions expressed are solely our own.
Alrighty, let's get to it. A bread and butter condition of pregnancy, gestational diabetes.
Gestational diabetes is heckin' common. Diabetes Canada quotes that 3 to 20% of pregnant patients will develop gestational diabetes. Thus, screening for it is a routine part of prenatal care. Typically, screening takes place between 24 and 28 weeks.
In some select cases, screening can take place in the first trimester. It is important to remember that first trimester screening is not to diagnose gestational diabetes, but rather to diagnose overt, untreated pre-existing diabetes. The Diabetes Canada website reviews some of the evidence regarding choice of test in this instance. The ideal test is not known. If a hemoglobin A1C is done, the cutoff is lower during pregnancy than it is outside pregnancy, and this cutoff is 5.9%.
So it's almost like pre-diabetes is considered diabetes worth caring about in pregnancy. Interesting.
Because of those placental hormones.
Yeah. There are many risk factors that could make you consider this early screen for diabetes. We will not go through all of them, but some to consider are history of previous gestational diabetes, history of a prior macrosomic infant, the presence of vascular risk factors, a history of PCOS, the presence of acanthosis nigricans, as well as a variety of medications, notably long-term steroids, atypical antipsychotics, highly active antiretroviral therapy, and anti-rejection drugs.
If screening is completed and negative in that first trimester, it must still be repeated at the usual time in the second trimester, between 24 and 28 weeks.
The main reason for screening is that we can try and treat the gestational diabetes to prevent complications. These complications include fetal macrosomia, neonatal hypoglycemia, hyperbilirubinemia, stillbirth, shoulder dystocia, C-section, and hypertensive diseases of pregnancy.
The typical routine second trimester screening can be done in one of two ways. The SOGC guideline recommends the two-step approach. However, they do concede that a one-step approach is reasonable. The Diabetes Canada guidelines state that either option is acceptable.
And either way, whether it's one-step or two-step, your patient is going to have to drink a horribly sweet drink.
The two-step approach involves having patients complete a non-fasting 50-gram glucose challenge screening test. This test can be abbreviated GCT or sometimes just GDS for gestational diabetes screen. Patients will drink the sweet drink and then have their blood sugar measured 1 hour later. The cutoff value is 7.8. If a patient's blood sugar is less than 7.8, they are home free. There is no gestational diabetes and they need no further testing. If the patient's blood sugar is 7.8 or greater, this means that they need to proceed to the second step.
The only exception here is that if the patient's first blood glucose level is 11.1 or higher, it is diagnostic of gestational diabetes, and you can stop it there without doing the second test.
The second step in the two-step approach is to complete the 75-gram oral glucose tolerance test. This is often abbreviated OGTT. This test will confirm whether the patient has gestational diabetes or had a false positive on that first test. Patients have to be fasting for this test. They have to get their blood drawn at 3 different points. The first time it's drawn is when they are in that fasted state. Then they get a blood draw at 1 hour after drink ingestion, and then 2 hours after drink ingestion. The diagnosis of gestational diabetes is made if any one of the following results occur: a fasting plasma glucose of 5.3 millimoles or higher, a 1-hour plasma glucose of 10.6 millimoles or higher, or a 2-hour plasma glucose level of 9 millimoles or greater.
Okay, so that is the two-step test, but some places use a one-step test. This method has patients proceed directly to taking a fasting 75 grams oral glucose tolerance test. However, the cutoff values for diagnosis are slightly lower than in the two-step method. Once again, there are 3 blood glucose results to consider with the OGTT. When doing the one-step method, the thresholds for diagnosing gestational diabetes are a fasting plasma glucose of 5.1 millimoles per liter or greater, a 1-hour plasma glucose of 10 or greater, or a 2-hour plasma glucose of 8.5 or greater.
We realize that is a lot of numbers. My recommendation is to just check out the Diabetes Canada website section of pregnancy and diabetes, where they have 2 very handy flowcharts going through the diagnosis for both the one-step and two-step screening options. The website also has a healthcare provider tool that you can actually just input your patient's results, and it will tell you if the patient has GDM. We'll have all those links in the show notes.
I like not remembering numbers. I'm going to use that tool. Okay, so we did the test, we put it into our tool, and I have a diagnosis of gestational diabetes. Now what do I do?
Honestly, this is where your fantastic diabetes nurse educators swoop in to help. These specialists will often complete patient teaching around the diagnosis of gestational diabetes. They will show patients how to test their blood sugars, alter their diet, increase their activity level, and, if needed, start insulin. They may liaise with endocrinologists or OBGYNs with an interest in diabetes to optimize patient blood sugars for the remainder of the pregnancy.
Ideally, it's nice to have some time with patients to review and discuss the diagnosis. Some patients can be really upset by this diagnosis, feeling a lot of blame and shame. It might be helpful to educate the patient that in later stages of pregnancy, the pregnancy hormones create a state of insulin resistance to help the fetus grow. This change is normal and expected, but for some patients who are more susceptible, this natural change surpasses their ability to adequately regulate their sugars. For those interested in a deeper pathophysiology dive, we will link an article to the show notes that reviews gestational diabetes, as well as the normal changes in insulin sensitivity and resistance in a healthy pregnancy.
Patients will have to start checking their own sugars for the remainder of pregnancy, and these numbers will help determine the management plan. The target numbers in pregnancy are a fasting sugar of 5.3, a 1-hour post-meal sugar of 7.8, or a 2-hour post-meals of 6.7.
Most often, you will see patients being asked to check their sugars about 4 times a day, typically once in the morning, which will give a fasting blood sugar, and then after their 3 main meals of the day.
And I think just important to remember, similarly of a new diagnosis of diabetes in any person, this is a huge undertaking for a patient, especially someone who's been otherwise healthy, never been on medications, or had to manage a chronic condition before, to be suddenly asking them to check their sugars 4 times a day and make a lot of dietary changes in a very short period of time.
Mm-hmm. And this 4 times a day is the goal, but for some people, even if they're just checking it once a day, that's a win. So working with your patients to meet their goals, and hopefully you're getting those multiple checks in, but sometimes people have busy lives and it's not something you're used to doing, so it can take a bit of practice.
Yeah, absolutely. So for ongoing management of gestational diabetes, it's often really helpful to have some experienced colleagues to help you along. A couple years ago, I had the privilege of talking with a fantastic dietitian who helped pregnant patients with gestational diabetes. She had just so many tips, but one thing she emphasized is the value of tailoring diet changes within a patient's cultural norms. For a patient for whom rice is a staple with most meals, asking them not to eat rice for weeks may not be practical. However, mixing in quinoa with the rice or alternating between the two might be. You'll likely not have time to dive into detailed dietary counseling and modifications or look up all options for a different patient population, but get your patients connected for the support that they deserve and need from experts to help them make changes that are acceptable to them and feasible for them and their families.
Yeah, I can't imagine if you already had kids at home and you were used to cooking a certain classic starch and then you had to modify that, but no one else in the family wanted to modify. This could get really hard.
Yeah, for sure.
Yeah. Okay, so some common tips you might hear that you can share with your patients to help manage their gestational diabetes would include some of the following. First of all, trying to have more smaller meals spaced out through the day. This helps reduce large variations in blood sugar levels. Number 2, choosing low glycemic index foods instead of high glycemic index ones. And number 3, reduce and space out the carbohydrates.
But importantly, don't cut out those carbs altogether. Patients still need to maintain a minimum of 175 grams per day.
Number 4, limit anything with added sugars. This includes juices, candy, sugar, honey, etc., etc. Number 5, choose high fiber foods and foods with more protein content.
For all of us non-dietitians, remember carbohydrates come in all forms. They include starchy vegetables such as potatoes or yams, beans, rice, sweet foods, fruits, lentils, etc. They are everywhere and are often present in very staple foods. You can understand why diet changes can present such a challenge to patients.
Because we can't get into all these details today, we will link a handy Alberta-based resource in the show notes that goes through some food options for people with gestational diabetes. The My Health Alberta website also has some good resources for patient teaching.
Once diagnosed with gestational diabetes, patients are typically given a 2-week trial of diet and lifestyle changes to meet blood sugar targets. If sugars remain high despite these changes, insulin is recommended. They may need ongoing titration to optimize numbers until delivery.
Common insulins you might see being prescribed in pregnancy include the following. For short-acting regular insulin, Aspart and Lispro might be used. Generally, insulin does not cross the placenta, but Lispro can start to cross over if the dose exceeds 50 units per day. For long-acting, you might see NPH, Glargine, Levemir, or Detamir.
All patients started on insulin should be counseled on the signs and symptoms of hypoglycemia, which can include sweating, shakiness, blurred vision, and dizziness.
In some instances, you may also see patients being started on metformin. Because the management decisions of medicated diabetes in pregnancy can get complex and are often beyond the realm of family practice management, we won't be diving any deeper into this aspect of gestational diabetes today. Again, make sure your patients are appropriately connected with a dietitian, nurse educator, gestational diabetes clinic, or an OB-GYN depending on your local practice pattern.
I think it's really important as well to make note here that in terms of the degree to which patients who are diagnosed with gestational diabetes are managed within family medicine will really depend on your clinic, practice setting, and what resources you have readily available to you.
I feel like that's a question I often had with diabetes is like, what do family doctors manage? What do OBs manage? And there is, in my experience, variability.
I've seen them as like a shared care sometimes. I think just like diet controlled, I think is totally family practice. And then insulin dependent, I've seen a mix of sometimes shared care. Sometimes it's connect them with a diabetes clinic and they can still be doing their low risk family provider for the rest of their pregnancy, and they like liaise with the diabetes nurse. Sometimes patients who have been started on insulin may no longer be eligible to deliver in your site, depending on what resources you have, often as it pertains to managing the baby after delivery. Shared care options might be a potential when a patient is getting a bit more complex, but otherwise still relatively okay to be managed within family medicine perspective. So I think just being aware of gestational diabetes, really knowing how to diagnose it, and then understanding what the referral patterns and practice patterns are within your local setup is very important to make sure that these patients are optimally managed throughout their pregnancy, delivery, and then for the infants postpartum.
Okay, so let's talk briefly about some extra antepartum monitoring your gestational diabetes patients will have. This may be something you're coordinating if you're a family physician who does a lot of this care, or potentially this is something OB's coordinating in shared care, depending on your area.
For all patients with gestational or pre-existing diabetes, additional monthly ultrasounds can be started at 28 weeks to monitor for fetal growth and amniotic fluid levels. Additional antenatal testing is often added in later in the 3rd trimester. However, depending on the type of diabetes, pre-existing gestational with diet control or gestational on insulin, and degree of hyperglycemia control, the timing of antepartum surveillance, and the frequency of ultrasounds or other forms of antenatal testing can vary. Testing frequency will typically be led by your OBGYN or MFM colleagues, particularly in these complex cases.
There are various options for fetal monitoring, including NST and amniotic fluid levels, or a full biophysical profile. Check in with your OB-GYN for local practice patterns.
When it comes to timing of delivery, this will in part depend on whether patients are gestational diabetes with diet control or if they have gestational diabetes that is with insulin control. It'll also depend on their degree of blood sugar control and if there are any additional concerns on antenatal testing. Typically, patients will undergo induction somewhere between 38+0 and 40 plus 6 weeks gestation.
Finally, it's important to remember that patients who are managing diabetes concerns in pregnancy are at higher risk for experiencing preeclampsia. Be sure you're measuring blood pressures and addressing any concerns raised by patients that could be suggestive of hypertensive disease.
All right, so let's talk briefly about intrapartum management. So the big thing to think about in intrapartum care is the prevention of hyperglycemia during labor, as well as monitoring for hypoglycemia. So hyperglycemia in labor still matters a lot, even though it's not going to cause that macrosomic fetus, but it can contribute to neonatal hypoglycemia after delivery. And intrapartum blood glucose targets should be somewhere between 4.0 and 7.0 millimoles per liter.
In labor, insulin requirements decrease and patients may not be eating. This means that any patient on insulin might need this adjusted or completely stopped. I kind of remember it's like how exercise or increases your insulin sensitivity, and ain't no exercise like delivering a baby.
Yeah. I'm always telling people, you just ran a marathon. It's okay to be tired. I found it very hard to find any guidance on specifics around this issue. Typically, what I have seen for patients with gestational diabetes on insulin is that if they are on low doses of insulin, this is simply stopped intrapartum. Often patients are not eating, and so they won't need any short-acting insulin in the same way as if they were eating meals. And sugars are being monitored throughout labor and can be corrected if required. For patients who are on very high doses of insulin, or if they're taking long-acting insulin, this long-acting insulin might be continued while the short-acting insulin is held while the patient is not eating. But honestly, these patients will be at a minimum a shared care patient and often more likely to be a transfer to OBGYN service who will make those calls for you.
Great. So let's move on to postpartum considerations for patients with gestational diabetes.
When it comes to the immediate postpartum management for gestational diabetes, all medications and glucose checks can typically be stopped at the time of delivery. Once the placenta is out and the pregnancy is completed, blood sugars should generally resolve.
We couldn't find any clear SOGC guidance regarding postpartum testing. An up-to-date article suggested that if gestational diabetes is present, it could be reasonable to forego testing in the postpartum period or perform a single test to ensure everything is normalized. If faced with gestational diabetes that requires medication, these can typically be stopped after delivery. But again, it could be reasonable to check for 24 hours to ensure sugars have normalized. Basically, we're kind of staying on the lookout for overt diabetes, which would necessitate ongoing treatment.
And this is actually what I've been seeing in training thus far as well. Whether or not you keep checking to make sure they go normal within 24 hours is super variable. And really, it's like doing checks for 24 to 40 hours, like while they're in hospital. There's lots of variability in practice depending on the patient's diagnosis, the degree of control, whether it's insulin controlled or diet controlled, and exactly how much insulin they were needing throughout the pregnancy. There's also depends on the degree of provider concern that the patient might actually have an underlying component of type 2 diabetes that's been affecting their diagnosis.
Fascinating. Interesting. This is very good learning for me. All right, so we talked about sugar checks. What else can be helpful in the postpartum period? Breastfeeding. Breastfeeding is strongly recommended in all patients who have diabetes, whether it's pre-existing or gestational. It has been found to have numerous health benefits for both the child and the mother. It can help prevent childhood obesity and help prevent the development of diabetes in the mother and the child. The duration of breastfeeding seems to further the protection from later development of maternal diabetes.
We always want to be sensitive in talking with parents about how they want to feed their newborn. Check out the breastfeeding episode for some hot tips from Patty about setting up this discussion.
Hot tips.
Many people will have a hard time initiating breastfeeding or may have had negative experiences previously. While no one should be forced into trying breastfeeding if they do not want to, consider raising the discussion in prenatal appointments to get a sense of your patient's preference. This gives you an opportunity to educate patients about the maternal and newborn benefits of breastfeeding, specifically in that context of diabetes. Patients can then have time to think about it and do their own research as they think about their method of feeding.
Further, patients with a history of insulin resistance might actually have a harder time breastfeeding due to lowered milk production, even though it's really good for them. If your patient is motivated for breastfeeding, this might be the patient you consider a perinatal or early postpartum breastfeeding clinic referral. Keeping or starting the patient on metformin may also be helpful for milk production in this patient population.
Yeah. And it's so important. I see so many people struggle like right after delivery and give up within those first 24, 48 hours. So it's so nice to have those conversations before, warn people it's going to be hard, encourage them when they're struggling, for everyone. But there's just so many added benefits for this patient population.
Another very important piece of gestational diabetes management for any family practice care provider to know is repeat testing in the postpartum period. Sometime between 6 weeks and 6 months postpartum, all patients who have had gestational diabetes in pregnancy should undergo a 75-gram oral glucose tolerance test to look for unmasked prediabetes or diabetes. How you interpret these tests is the same as diagnosing diabetes at any other time of life. Refer to your favorite diabetes resource and use the same cutoffs you are familiar with for family practice for fasting glucose, 2-hour plasma glucose, and hemoglobin A1C. So what test should we do? Should we do the 75 oral glucose tolerance test? Should we do an A1C? Should we do a random glucose?
I think that all the guidelines say you should do the 75-gram OGTT, but obviously sometimes that's difficult to access. So I think it's reasonable and okay to do the hemoglobin A1C, which is often an easier test for patients to do. So that's fine. But the guidelines say the 75-gram OGTT.
Awesome.
There is a very high risk of recurrence rate for gestational diabetes from pregnancy to pregnancy. So it's super important as a family provider taking care of patients during this interpregnancy interval and preconception interval and early pregnancy interval to tell patients to ensure that they engage in as many health promoting behaviors. So diet modification, exercise, general healthy recommendations we give for everybody.
Finally, all patients with any type of diabetes are at higher risk for postpartum depression, so appropriate screening on history should be done in postpartum visits to pick this up.
All right, so that's a lot of information. So we'll do a very quick summary of gestational diabetes. First off, screen everyone between 24 and 28 weeks gestation using either a 1-step or 2-step method depending on local practice. 2, connect all gestational diabetes patients with the appropriate care team who will help them either manage with diet alone or start them on insulin to optimize glucose control. And 3, always make sure to complete postpartum screen to look for any new diagnosis for prediabetes or overt diabetes.
So we spent a lot of time talking about high blood sugar levels in the pregnant person, but before we sign off, we're going to talk quickly about low blood sugars in the newborn. These topics go well together because hypoglycemia is one of the main concerns newborn care providers will have in the early newborn period for an infant born to a parent with gestational diabetes.
There are many other risk factors for hypoglycemia in the newborn period as well. Some of these include both large and small babies, preterm infants, and maternal labetalol use. Remember, labetalol is a very commonly used antihypertensive in pregnancy, so make sure to remember that for those babies.
Signs of newborn hypoglycemia can vary. Among the most common signs is jitteriness or tremors. Other signs include atypical vitals with either tachypnea or occasional apneic spells. They may also have a high-pitched cry, lethargy, and difficulty feeding. Unfortunately, many of these signs can be subtle, which is why there are sugar screening protocols that can be initiated for infants at risk, so hypoglycemia does not go unrecognized and untreated. This is one of my favorite questions to pimp med students on because they literally can't get it wrong. Any symptom could possibly be a symptom of hypoglycemia, so I always say any baby that's doing something funny should have their sugar tested.
Yeah, and I didn't include it in the vitals here, but if a baby has a low temperature, the first thing you should do if they have a low temperature is check their sugar as well. Abdullah actually had a case recently where he had a baby. It was low temperature. He took the temperature and was like, oh, that's not right. That can't be their temperature. And took it again and it was low. Then he took their sugar and it was a critical low. And then they had to get IVs going. And yeah, it was a big deal. And it was a low risk baby. I think they were a totally healthy family. There was no reason that this baby should have tanked. But they did.
That's such a good story. I think we should keep it. And I'll just mention that Abdullah is Kyla's rock star ops nurse partner, for anyone who needs to know. And then Abdullah will get a shout out.
I'll have to tell him to listen to this episode.
Exactly.
The duration of the screening period differs depending on the risk factor for which screening was initiated for the hypoglycemia. Today, our focus is on infants born following a pregnancy complicated by diabetes. Generally, these infants require screening for a minimum of 12 hours. If all is normal, screening can be stopped after that time. There are longer screening protocols for different risk factors or hypoglycemia. For example, if an infant is small for gestational age, those infants will often have their sugars measured for up to 24 hours. And you might even find that there are site-specific differences regarding these protocols as well.
Yeah, I regret committing some of this stuff to memory as a med student because there's just a good protocol for it always, I find. The typical blood sugar screening routine includes an initial level drawn at 2 hours of age and then every 3 to 6 hours until the end of the protocol time period, typically somewhere between 12 and 24 hours after birth, depending on what their risk factor it was. Importantly, if an infant becomes symptomatic at any point in time, a blood glucose level should be drawn immediately, regardless of when the last check was done. If a baby's doing anything funny, check their blood sugars.
There's a lot of nuance in this topic, so rather than us talking through it all, it is probably easiest to head over to the CPS statement on the topic and review that. We will also make sure that we link the CPS algorithm for management of hypoglycemia in our show notes.
In short, things to remember for hypoglycemia are 1. The cutoff for intervention is a glucose level of 2.6. 2. Depending on the clinical picture, options to raise blood sugar levels include formula supplementation, an increase in breastfeeding, or administering 40% dextrose gel at a dose of 0.5 milliliters per kilogram. Sugars are then rechecked 30 minutes after whatever intervention is chosen to ensure an appropriate increase in blood glucose has been obtained.
If feeding, either formula or breastfeeding, is being used to treat hypoglycemia, the amount of intake should be measured. So the goal is the equivalent of 4 mils per kilo per hour. This translates to about 8 mils per kilo every 2 hours. Despite the need for greater intervention, ideally skin-to-skin should still be encouraged as much as is feasible.
Our reviewer also mentioned the role of hand expression to aid in milk production and supply. This is worth teaching to your patients as it can be a great way to stimulate their breasts to promote milk production. Remember, the good glands and high demands are key to milk production. Expressed milk can be used for top-ups if available, which is great for baby.
If the infant is symptomatic or not tolerating oral options, or glucose is continuing to fall, then an IV with D10W needs to be initiated. Dosing is reviewed in the CPS statement, flowchart, and position statement. The initial hourly rate per acorn is 3 mils per kilo per hour of D10. It can then be increased if you are failing to meet target blood glucose levels. In these trickier cases, a call to your neonatal team is a good idea.
If the initial blood glucose is less than 1.8 millimoles per liter, this is a critical hypoglycemia result, and IV dextrose should be started immediately.
Depending on your site, the initiation of an IV for glucose administration may be the threshold for newborn transfer to a center capable of higher levels of monitoring and intervention.
It is also important to know that we do expect the hypoglycemia to get better in those first 1 to 3 days following delivery. If you are having problems with hypoglycemia after baby is beyond 72 hours, this infant is moving into the realm of persistent hypoglycemia and needs further evaluation. Their blood sugar targets could also change at this point. So if not already involved, your neonatal or pediatric endocrinology team should be consulted to help out. This could be something weird like a metabolic syndrome.
The consequences of untreated or persistent hypoglycemia include various neurological sequelae. Because of this, it is very important to get hypoglycemia recognized and treated, and then if the infant is not responding well to those initial interventions, to escalate the care and get specialists involved.
The risk for long-term neurological sequelae depends on the degree of hypoglycemia. Is the infant symptomatic, and is the hypoglycemia persistent? Furthermore, there may also be additional risk factors that can cause the infant to have a bad neurological outcome.
Okay, well, that about wraps it up for gestational diabetes and our brief review of hypoglycemia screening and management in the initial newborn period. So let's review some quick pearls.
1. Pregnant patients should be screened for gestational diabetes by a 1 or 2-step process between 24 and 28 weeks gestation. Use the Diabetes Canada website or the SOGC guidelines for cutoffs.
2. Patients diagnosed with gestational diabetes get 2 weeks to trial dietary changes. If sugars cannot be controlled in this interval, then medications, typically insulin, should be initiated.
3. Newborns are at higher risk for hypoglycemia when born to a gestational parent with any type of diabetes. Their blood sugars should be monitored carefully for at least 12 hours. Check your local hospital protocol.
4. Neonatal hypoglycemia is an emergency that needs urgent management. If an infant is failing to respond appropriately to therapy, escalation of management and involvement of neonatology services is required.
5. Breastfeeding has long-term benefits for both the newborn and the gestational parent. It is strongly recommended for patients with diabetes, but unfortunately, these patients can also struggle with low milk supply. Consider discussing the benefits of breastfeeding with your patients so they can make an informed choice regarding feeding preferences. If they would like to breastfeed, consider early or even prenatal connection to a breastfeeding specialist for support with skills like hand expression and to discuss medications like metformin as indicated.
All right. Well, that's it for today, folks. Thank you so much for tuning in. Remember, you can connect with us at hello@thegeneralist.ca or via Twitter or Instagram. If you're studying for the CCFP or just want to learn more about family medicine topics and resources, be sure to check out our main CCFP study podcast and their website. Thanks again for listening. We hope to be back soon. Until then, good luck on the wards.